Hi, I'm Mabel Jung, and you're watching the World Healthcare Congress Interview Zone. I'm so pleased to have Dr. Gail Wilensky here. She's a senior fellow at Project Hope, among the many other titles that you've held over the years. Your experience with Medicare is extensive. The program has grown to such phenomenal numbers. Is this what you envisioned when you first started working with the program years ago?
It's hard for me to believe that it's been 20 years since I ran the Medicare and Medicaid programs, but then I had the opportunity to chair the Physician Payment Review Commission and the Medicare Payment Advisory Commission, so it gave me more than a decade of hands-on work with Medicare. At some level, we foresaw painfully well exactly where we are today. For other areas, not so much. We've known that baby boomers were going to go start retiring in 2011. That's happened, and we are in the midst of a huge amount of pressure because we're going to double the population on Medicare by the time all of the baby boomers have retired. In 1990, we knew that was going to happen, and we knew that would put tremendous pressure on the program. What we didn't forecast as well as we might have, probably should have, is that we would also have experienced long periods with rapid growth in spending in both Medicare and in the rest of the healthcare system. And that, of course, just exacerbates all the problems of the retirement of the baby boomers. Right now, literally, this year, the year before that, we've seen unusually slow growth in Medicare per person and in healthcare spending in general per person. But it's very unclear how long we're going to see this kind of slow growth, because a lot of it may well be due to the extended recession and the hit on middle class wealth that came when 401ks and housing values were hit. Some of it might be attributable to some of the change that's being undertaken in both the public and private sector to try to slow spending. Whether that will be sustainable or not, I'll tell you in 5 years.
Well, you know, when you say slow growth, it's really a drop in the bucket because the program is already one of the costliest pieces of the budget. I mean, the Medicare and Medicaid programs are running at what per year now?
Well, the Medicare just by itself is $550 billion.
Okay.
Medicaid of federal and state together is even larger. And when we look out ahead, there is no way we can solve our debt and deficit program without doing something about entitlements. They are going to be at roughly 10.5% of our GDP when we look out another 20, 25 years. That's double where they are right now. It will put enormous pressure on everything else that we can do. That's what people need to understand. When we say healthcare spending grows faster than the economy, what that means is we will see pressure on everything else that we want to do. Education, defense, investing in our future, the infrastructure, all of that becomes very hard if we can't keep healthcare spending growing at about the rate of the economy.
Well, there have been some suggestions of bipartisan solutions, such as raising the eligibility rate, for instance, the eligibility age. Yeah. What do you think of that?
I support that notion. I have been for a number of years. I don't want to promise too much because the youngest people on Medicare, the 65 to 67-year-olds, are the smallest users and the healthiest population. We need to think about 70 as a more reasonable retirement age rather than 65, which was adopted by Disraeli and built into our Social Security and Medicare systems when they were adopted, because people live so much longer and for the most part are in a relatively healthy state, able to work. This is a broader issue. We need to adopt fiscal policies, encourage employers to keep people around. We're going to have some help in this, and the reason is because we have had very low fertility rates, not at replacement for our population. And while it's hard to understand this now because we're still feeling the effects of the recession, we're going to have a real labor shortage because there are going to be so many people getting older, and those that are coming in at a slower rate. Of course, it may depend what we do about immigration as well, which has frequently been a way to try to help beef up your labor market.
Okay. Well, Dr. Wilensky, we know a lot about the bad news. What's the good news?
Well, there's lots of good news. The fact that we are living longer and living healthier is terrific news. We used to have large numbers of people dying from heart attacks and strokes and cancers, and in most areas we have seen substantial progress, and with the new biologics that are coming on the market, a lot of hope that we will make real progress in fighting cancer. And right now we're seeing a lot of interesting innovations in terms of how to try to deliver healthcare smarter and cheaper, or if not cheaper exactly, at a slower and more sustainable rate of growth. The private sector is trying lots of things to encourage physicians and hospitals to provide more efficient care, more high quality care, more clinically appropriate care, and to encourage the users of healthcare to go to those places, lowering their coinsurance or lowering their premiums, or encouraging smoking cessation by lowering premiums for people who engage in it. So there's a lot of positive movement. We've just got to really grab it and drive it home, because we are going to see the effects.
How do we do that?
Well, that's going to be the big debate. We have a lot of small demonstrations and pilot programs going on in Medicare and in the private sector. We can give ourselves a couple of years to try to understand what seems to work and some sense about whether it's scalable. I think by the time we are having another president elected, we have got to be on the path of serious change, decided which of these innovations looks like it has the most promise, and start driving the broader delivery system in that direction. Not necessarily one direction, but a set of changes that reward institutions and clinicians for providing the kind of care we want to see, and discouraging those who aren't. We don't have much more time than that.
Fee for outcome is
Yes.
what you're supporting.
Yes.
Okay. Well, thank you so much, Dr. Wilensky. A real pleasure.
Thank you. Great to meet you.
Great to see you. And I'm Mabel Jong. Thanks so much for watching.